So this is EMS Delivery and the Affordable Care Act. My name is Baldwin Robertson. I'm IAFF Legal Counsel. And with me is Leo Tokar. He is the Senior Vice President with Lockton Companies, a consultant for employee benefits and also a consultant that provides a consultant with healthcare providers. Lockton is one of our preferred providers with the IFF under a resolution adopted at our convention in 2012. The Technical Assistance Department is providing a list of preferred providers who can provide assistance to our affiliates in consulting and healthcare related fields. This module is about Obamacare, the Patient Protection and Affordable Care Act, and its impact on emergency medical services. I think, however, for the first few minutes, I'm going to talk specifically just about what the Affordable Care Act does and how we got to that point where we needed, in a lot of people's eyes, such a far-ranging and ambitious statute like the Affordable Care Act. And how the Affordable Care Act and other market-based forces are forcing a lot of key players in the healthcare world to pursue strategies to try to control healthcare costs. And finally, how those strategies and other different kinds of new business models and service models that are evolving as we speak present both opportunities to the EMS world and substantial challenges. The PPACA or PPACA or Obamacare or just the Affordable Care Act had a lot of very ambitious aims. The first aim was to expand the coverage. We have anywhere from 30 to 40 million people currently without health insurance for various reasons. Some of them by choice, they don't want to spend the money. Some of them because of discriminatory policies of insurers. Some of them because they simply can't afford it. But one way or another, we wanted to expand. Congress and White House wanted to expand coverage of health insurance. They also wanted to pursue real reform of the way healthcare delivery, the way the healthcare delivery system provides healthcare in ways that reduce costs. If you look at the federal budget projections for the next 5, 10, 20, 30 years, probably the most important single component of that is driving budget deficits for that time period is Medicare and to a lesser extent Medicaid cost growth. So the Affordable Care Act is not just a law that reforms the health insurance system. It's really something that is meant to try to control the budget deficit. And in fact, the Congressional Budget Office has concluded that it's going to save somewhere in the neighborhood of $120 billion over the next 10 years. So now it's also going to involve some substantial taxes and expenditures by the federal government. I'm going to get into that. But one of the most important ways, or one of the most important aims of this law is to try to control healthcare cost growth. It also wanted to tackle some of the more egregious examples of discrimination against the sick and the injured. You've all heard of the stories of people being thrown off of health insurance, thrown out of their health insurance plan because they reached some lifetime limit on healthcare expenditures, or someone can't change jobs because they know that if they left their current job, they wouldn't be able to get health insurance on the individual market because of some pre-existing condition. And in some instances, people who simply are in some kind of demographic that insurers believe is a high risk for high health expenditures, they've also been either refused health insurance or been presented with exorbitantly high health insurance premiums. And overall, there's also this aim of the statute to try to bend the curve on healthcare expenditures nationally. As I'll explain in a few slides, we have an increasing percentage of our economy that is going strictly to health insurance and to healthcare costs. And the problem there is that that's money that could be spent on a lot of other more productive areas in our economy. There are also some secondary aims. There's sort of small portions of this statute that involve innovations in billing practices, innovations in models of care, which we're going to get to. Some of this is fairly minor in terms of, in comparison to the other really dramatic elements of the statute. But I think for this discussion about EMS delivery, it's really one of the core issues. So what am I talking about when I talk about healthcare inflation? This is a table that shows healthcare inflation versus ordinary inflation, CPI, I believe CPIW, since 1970. And you can see, and it's a little bit hard to see on the screen, I apologize for our problems with the contrast, but the white dotted line is annual healthcare inflation. In 1970, healthcare costs were growing annually by over 10%, whereas the economy prices overall in those very high inflation years were only growing by about 6% a year. And there was a brief spike in 1980 when you had a real inflation crisis, but for the most part, healthcare inflation has outpaced ordinary inflation by a substantial margin for almost the entirety of the past 50 or 60 years. And as a result, we're seeing that, again, our healthcare expenditures as a nation are growing dramatically every year as a percentage of our economy. In 1960, this chart shows that in 1960, we spent about 5.2% of our national GDP on healthcare costs. In 2011, we're spending about 18%. I could list off for you a number of other countries, industrialized democracies, where they've managed to keep that number between 9 and 13%. And that represents to us, to people who are concerned about the overall economy especially, that represents a real concern for how we're spending our money nationally. And that also means that's going to impact people's pocketbooks. If you're spending 18%, if the nation is spending 18% of its economy on healthcare, that's got to come out of somebody's pocket. And in fact, it's really impacted health insurance premiums, especially over the past 20-some years. This is not exactly health insurance premium, this chart. I don't have that data available. But the per capita expenditures on health insurance have far outpaced other factors like the aging of the workforce or of the population in general, or even outpaced poverty levels. We're talking about something that is eating into working people's income. Look at it this way: if you made X number of dollars an hour in 2001, and got wage increases that basically met ordinary CPI inflation, today you would be making less money per hour in real terms than you were in 2000 by a substantial margin, and that's because you were paying for health insurance. So health insurance premiums are going up, healthcare costs are going up, they're impacting our economy, they're impacting our federal budget, and it made sense at this point. Oh, okay, and you also had these other problems. You had the barriers to insurance. You had discriminatory practices by insurers, who are, after all, for-profit companies. You had the denials for pre-existing conditions. You had the fact that smaller businesses were struggling to compete in the labor market because they could not negotiate for low-cost health insurance for their employees because their pool of employees was small compared to larger employers. even larger employers actually were struggling to get good rates on health insurance. And of course, what do employers do in that situation? In almost all instances, they're going to try to put that cost back onto the employees in terms of lower wages, higher contributions by employees to the health insurance premiums, higher deductibles, things like that. You also had a problem with the overall structure of the system, which is somewhat unique to the United States, which is that we have such a large population of uninsured, and the outcome can be that those people who are uninsured, who suffer some kind of catastrophic health emergency and show up on the front door of an emergency room, they're not going to be turned away just because they can't pay, but someone eventually is going to pay for the health care that they receive, and usually that's going to be either somehow transferred over to higher premiums or higher charges by the hospitals to the insurers. So the statute the statute is extremely ambitious. It sought to tackle all of these problems in one fell swoop. One of the ways that it sought to do it was to basically get people who aren't insured into the insurance market as a way of either by forcing them or by incentivizing employers to provide that insurance, and as a way of trying to control health insurance premium growth. But it was an important baseline that the Congress had to work from, which is that they wanted to build from the existing system. So no single payer plan or anything like that, but simply build on the employer-based healthcare system, but expand it. So they added the employer mandate, which I'll talk about in a second. They added an employer mandate forcing employers of a certain size to provide health insurance that is affordable to their employees. They created an individual mandate, that is, individuals who do not have access to employer-based health care now have an obligation to either obtain insurance for themselves on the individual market or pay a penalty, what the Supreme Court has now said is a tax, if they do not obtain individual health insurance. That creates a much larger pool of consumers of health insurance, and as a result, the insurers accepted in the political process and really as a matter of policy that they now cannot make some of those impose some of those denials of coverage and those discriminatory practices that I talked about. So there are these requirements that are now imposed on health insurers if they are going to participate in the insurance market in a given state. There's also a belief that insurers should not profit exorbitantly from this increased customer base, as it were. So there is something called the medical loss ratio rebate, MLR, which I'll talk about. It basically caps the amount of profit that an insurer can make if it's participating in the system. And because so many millions of people are being basically forced into the health insurance market, there is obviously some cost issue for a lot of individuals, and so there are what are called premium subsidies. These are subsidies that are administered through the tax system and through the exchanges, which I'll talk about, so that if your income falls below a certain threshold, you are entitled to a certain, and you are on the exchange, purchasing health insurance through the exchange as an individual, you will receive subsidies from the federal government on all or some of the insurance premium. There's also some small tax credits that are used to incentivize the smaller businesses to purchase health care for their employees. And there's these exchanges, which I'm sure you've heard stories about so far. And these are basically marketplaces that are invented and managed through web portals in given states. Right now, there are 18 states, I think I have that right, roughly 18 states that are administering their exchanges themselves, and the remaining states are all going to be administered through the Department of Health and Human Services. As I said, there are subsidies for individuals, and it represents a real redistribution, to use a loaded term, of payment for health insurance for individuals. It is tagged to the poverty level as defined by the Department of Labor. If you make up to 400% of the federal poverty level, you will receive, and you are purchasing health insurance on one of these exchanges, you will receive a subsidy that is tagged to how close you get to that 400% level on your health insurance premiums. And this is going to represent a real reduction in the price that people might have otherwise paid for health insurance when they were buying it on the exchange individually. Yeah. Well, it's the way it's going to be. The question was, does the money go directly to the insurers? And I think the ultimate answer is yes, because it's not being cut directly. It's not a check cut directly to the insured, but it's administered through the exchange. At least that's the theory. And there's some real concerns there with how that's going to be administered, because there are millions of Americans who don't even have a bank account, let alone a credit card or some other way of being able to be charged for the premium under the exchange and then have the subsidy be funneled on their behalf to the insurer. And those are real challenges that DHHS is struggling with. I think it's DHHS or IRS, or they're all really struggling with it. But I think the bottom line is that it's a subsidy that I believe is administered through the exchange and is paid through the Medicaid program as administered by DHHS. But you might actually know that.
And it does go, the subsidy does go to the insurance company as an offset to the premium. So the feds pay a portion and then the individual pays a portion, the remaining portion after the subsidy to the insurance company.
And actually, one interesting thing that is worth keeping in mind here is that the rate that the insurer charges is not tagged at all to whether or not the subsidy is in place. So, for instance, in California has announced its rates, a few months ago it did, for the individual insurance market based off of different regions in the state starting in 2014. And arguably I think those rates are very competitive. They are significantly lower, however, for an individual if they are entitled to a subsidy. So, I mean, I looked at what I was paying as a 39-year-old, healthy without any pre-existing conditions or anything. I looked at what I was paying for my insurance, and I wanted to move to California immediately. I mean, it's just, it's way better. It's literally hundreds of dollars better. I'm in a small employer. I'm a partner in a law firm, which is a small employer. We have no bargaining power with our insurers to get a decent rate for our employees. So, speaking of employers, there's also this employer mandate. This applies only to large employers, and good luck trying to figure out exactly what that means, but the general theory is that it's 50 or more full-time employees. You can probably guess that there's ways to play games with who's a full-time employee and so forth, and that's a real concern, including some concerns that have been raised by the AFL-CIO on how this will impact full-time versus part-time employees. But the general rule here is that employers, if they have more than 50 full-time employees, must provide affordable health insurance to their employees and their dependents, which does not include spouses, or they will pay a penalty to the federal government. And that includes, by the way, municipalities. So this is everybody. Municipal employers that have more than 50 employees, which is probably most municipal employers except for maybe fire protection districts, they all are going to have to provide so-called affordable health insurance to their employees, or they will pay either a $2,000 or a $3,000 penalty to the federal government. The idea here is that even though the penalty is far less than it might cost to provide for the health insurance for that individual employee, the belief here is that since something like 60% or so of Americans with health insurance get it through their employer, something thereabouts, 60 to 70s, that a lot of employers aren't going to walk away from providing health insurance to their employees when they've already been doing it in the past. This is really about forcing the big employers that don't currently provide affordable health insurance to their employees to start doing so. So the Walmarts, the McDonald's, et cetera. Did you have a question, sir?
I work for a combination department. We have residents that do put in more than 30 hours a week. Will the districts be required to cover them with health insurance? Does it compensate minimally? They're kind of a trainee, if you will.
Yeah, you know, that's a great question, and I don't have a good answer on it, in part because there's still some guidance coming out. I mean, maybe you'd have a good, make a good guess on that.
Can you hear me okay? Anyone that is a W-2 employee and that works 30 hours a week or more on an ongoing basis, so is not truly a seasonal employee brought on to satisfy a peak need, then that means you have the obligation to provide that individual with a basic level of coverage at an affordable rate as defined in the regs, or you are subject to a penalty. It doesn't mean that you will necessarily pay the penalty. It means you have the risk of a penalty. If that individual goes and get a subsidy through the exchange, you get hit with a penalty. And so it's something that you should make part of your workforce planning, because it is a risk, and you have also an obligation that also being in part a publicly funded entity may be looked upon poorly if you don't.
Now, part of the solution to that may be that they only have to make affordable health insurance available to that employee.
Correct.
So a lot of your part-timers and volunteers most likely have insurance through whoever their full employer is. And so the combination department may simply make available some bronze level plan that they're not going to want because of the high deductible. And so as long as they make it available, they will be compliant. But then the question is, how are they going to negotiate? They'll have to negotiate with their insurer, the health insurer, to provide that plan, and that will impact their overall health care costs. It's probably why a lot of the smaller employers are going to want to have the ability to purchase health insurance for their employees on the exchanges. And we're seeing that in some states. So as I said, the employer mandate, it's out there, it's going to happen, we think, but it's not going to happen next year. It was going to happen next year, but I guess a month and a half ago or so, the DHHS announced that they were going to postpone the implementation of the employer mandate for 1 year. Now, the individual mandate's still going forward. Premium subsidies still going forward. Exchanges are going to be stood up, apparently, allegedly, in 2014. All this is going to happen except for the employer mandate. And so we'll see how that unfolds. The individual mandate is the other sort of big component here in terms of how this is radically really, the radical steps that are happening to change the insurance market. And as you probably know, this was one of the main topics of debate in the constitutional challenge to Obamacare that was decided last year. The statute basically says that if you don't have access to health insurance through your employer and don't take that insurance, and also do not obtain insurance in the individual market through these exchanges, you will be paying a penalty starting in 2014, fairly small. You'll be paying basically the federal government $95 or 1% of taxable income, whichever is smaller. That will increase to $325 or 2%, and $700 or 2.5% in 2016, and then that $695, that's going to be tagged to ordinary inflation, CPI-W or CPI-U, something like that, thereafter. So there may be a financial uncertainty. Really, there almost certainly will be a lot of people who will simply say, health insurance is going to cost me $1,200 a year or more on the individual market. Say a 27-year-old who is perfectly healthy is going to say, forget it, I'm not going to spend $1,200. I'm going to pay this $695. And so we'll see some people who simply won't get onto the health insurance market. And so the free rider problem may continue in that respect. However, some of this revenue is being expected by Congressional Budget Office and is being used to offset some of the overall cost of Obamacare to the federal government. Like I said, it's all kind of woven together here. You've got an employer mandate and an individual mandate, which is forcing a lot of individuals into the health insurance market for the first time, either forcing them or subsidizing their ability to enter into the market for the first time. But the other side of that coin is that health insurers are going to have to provide more access to health insurance. So children under 26 must be included if it's requested by the parents of those children on the parents' health insurance plan. There are now mandates to the health insurers to pay for certain kinds of wellness and preventative examinations and care. And also there's going to be tighter regulation, at least in some states compared to before this act, with respect to how they report the benefits provided by their insurance plan. This is really meant to kind of work together with the whole exchange idea, which is to give consumers of health insurance the ability to compare apples to apples when they're deciding whether they want to go with Aetna or Cigna or Kaiser or whoever. The websites are, if anyone's ever looked at ehealthinsurance.com, which is a kind of a private sector attempt to try to make apples to apples comparisons, I think it's going to be, the regulations are intended to try to force that kind of apples to apples structure. Real quick, there are other things that the insurers have to do. Like I said, there's going to be a cap on the profit margin of health insurers. The so-called medical loss ratio basically says that 85% annually of an insurer's revenue must go to health care expenditures. So that really caps their profits. It also caps, by the way, that 15% is not all profit. That will also be certain administrative costs. So they have an incentive to control their administrative costs because that's going to eat out of their profits. Now, some of you may have already experienced this. This MLR rebate has actually been in effect now for 2 years. If the insurer has determined with its annual self-audit that they have spent less than 85% of their revenue on healthcare costs, they must rebate the difference back to whoever their customers were, whether it was the employer that purchased the health insurance for their employees or the individual purchaser of health insurance on the individual market. Like I said, there are also these subsidies. There are tax credits that are being offered to small businesses to incentivize entry into the health insurance market for small businesses. And there are these restrictions on discriminatory provisions that were in place, and like the lifetime limits and rescissions, and that's already in place. In fact, that went in place this year. Next year, there's going to be much more of this is going to be going into effect. The individual mandate and the subsidies, as I said, are going into effect. The exchanges are being stood up basically this fall and are supposed to be in place for at least the individual market in 2014. There's going to be a complete ban on any insurer being able to deny an individual health insurance because of a pre-existing condition. But this is also going to dovetail with a lot of, well, let me say, because of all these changes, because of the impact on health insurers' profit margin, because of the MLR, because of the cost control efforts under Medicare and Medicaid that are part of this act, because of the increased strain on the healthcare providers, which we'll talk about in a second, there are going to be some real challenges to deliver economical, low-cost, or at least lower-cost healthcare. We're already seeing the strains on the profit margin for healthcare providers. You're seeing more and more doctors who are leaving their own private practice and going to work directly for hospitals. You're seeing a healthcare market or healthcare provider market that is struggling to try to catch up with all the changes. And this is partly because, we're spending 18% of our income on healthcare, and that's affecting everyone. And this is partly because of the Affordable Care Act. One thing I didn't have a slide on was how some of the some aspects of the Affordable Care, some provisions of the Affordable Care Act are providing for innovation grants and other new ways of trying to control healthcare expenditures, either by changing the way hospitals can bill Medicare for a patient, or changing the way the healthcare costs of a given Medicare or Medicaid provider are billed. But one way or another, what we're seeing is the healthcare system, the healthcare provider system, is facing dramatic change, and the change is happening extremely quickly. We're seeing problems with also with the regulatory framework, because the healthcare market is still going to be regulated by the states in many instances. It's not all going to the federal government. We're seeing the changes that are happening in some states are happening faster than in others. I mean, if you look at California, California was a state that fully embraced the Affordable Care Act, and the state legislature passed legislation authorizing its new exchange to very aggressively pursue cost controls as it considered bids from insurers for health insurance to be provided to individuals on the exchange. And the results were, I think, pretty impressive. I think some other states are not involved in the exchanges at all. And other states have not as aggressively pursued it, or they don't have the kind of pool of new customers, as it were, that they can really point to. So some states have announced insurance rates that will be available to individuals on the exchange next year that really aren't particularly competitive, or at least they don't look competitive given healthcare cost growth over the past 3 or 4 years. So we're seeing a mixed bag there, and I think, but one way or another, we're going to see these changes in the way healthcare providers are going to be billed and the way they're going to provide healthcare to patients that Leo's going to talk about. He's much more knowledgeable about it. I think let me just talk real quickly about the Supreme Court decision last year. The decision had really two major components. One was whether or not the individual mandate was constitutional, and the other was whether or not the federal government could force states to expand their coverage under Medicaid. Right now, or that is prior to the statute going into effect, the states received money from the federal government and provided Medicaid coverage for those up at or below the federal poverty level. The statute provided additional funds to the states for them to expand that coverage to 133% of the federal poverty level. Now, what the statute actually said was, hey, states, you have to provide this expanded coverage or we're taking away all of your Medicaid money. And that was really the challenge. That was the subject of the challenge before the Supreme Court. And what the Supreme Court said was, what the federal government giveth, it cannot taketh away. So what you're seeing is some states have chosen not to expand their Medicaid coverage to that 133%, and therefore they're foregoing that additional federal money, but they're still getting the federal money that they were getting in the past. And that's creating probably some political pressures in many states. I mean, in Arizona, the governor infuriated a lot on the political right by accepting Medicaid, the expanded Medicaid, because that means that's federal money coming into the state, and she wanted the money. There's some states that are refusing to do that, and that's pretty controversial. I think probably that over the next few years, you're going to see a lot of healthcare providers who are going to be demanding that their states accept that federal money, because otherwise they're not getting the money for the care they're providing for that little slice of people between 100 and 133%. So that's kind of the environment that we're in. The environment, the law hasn't solved. There are a lot of problems, and there are still real problems that need to be addressed. And there are all kinds of solutions out there, some of which seem like they might work and some of which the jury is still out. A lot of things that we're advising our affiliates to look at in terms of trying to control healthcare costs are things like claims audits, getting consultants to take a look at their healthcare costs, especially if you're self-insured. But also there are these other solutions that haven't been, that the IFF has not played a role in, which we're trying to build some interest in amongst our affiliates right now, and that's what we're going to be talking about for the rest of this program. A lot of this, the new world that we're in, it rests on the fundamental fact that there are going to be between 20 and 35 million new customers who are going to have health insurance of some kind or another. That means they're going to be entitled to free preventive medical examinations annually. They'll be entitled to certain wellness programs, and they'll be entitled to basic health care on a wide range of areas that will be paid for by their insurer. That's going to mean an already strained network of primary care providers is going to be put under greater strain. That's going to mean emergency rooms, which are the healthcare provider of choice for a lot of these individuals, are going to be facing even more strain. And meanwhile, we have the already pre-existing problems, such as hospital readmissions and inadequate patient care for various reasons that are causing long-term healthcare problems to linger, which increases costs, and so on. So there are a lot of these innovative ideas that are out there, and Leo's going to talk about how IFF affiliates and how EMS departments and fire and EMS departments can start to get involved in some of these innovative ideas, things like health literacy programs, community paramedicine, maybe even fire station-based clinics. And we think that in some instances, IFF departments are particularly well positioned to take advantage of some of these new developments in healthcare. First of all, there are, just like there are shortages of primary care providers, doctors, there are shortages of nurses and other medical care providers, but there are EMTs and paramedics in almost every fire station with 24/7 access. They're in people's communities. They have mobile apparatus. They have the trust of their local populations. They have the training and the experience to provide some of this care that doesn't require an MD or a nurse. And they have the experience and they have the record of reliability to be able to build the relationships with the stakeholders to try to provide this care. I don't know what time I'm at, but and Leo's going to talk about this very effectively. But as he's talking, let's think about who the key players are in your individual jurisdictions. Every state is going to have a different model, and let me just say that in one state you might have a state medical director who believes that the scope of practice regulations don't include, say, community paramedicine. In another state, they may think it's perfectly fine. We've had different experiences in different states. In Minnesota, the choice was to go forward with a legislative solution to really authorize development of community paramedicine programs in the state. So you're going to need to be engaged with your state associations, who are going to need to engage state legislatures on this. There's going to be some talk here about partnerships with hospitals and physician groups. directly with health insurers. And of course, in many ways, this can be pitched as a way of saving taxpayer dollars, because a lot of this does go to state and local budgets. I will say, just as a last point, the IFF Technical Assistance Department has compiled a database of the regulatory regimes of every state in the U.S. to try to get a sense of, and to really break down what might need to be done in a given state to try to accomplish some of these new alternative models of healthcare, that is, to accomplish an IFF and a fire and EMS role in these new models of providing healthcare, whether it's community paramedicine or local clinics, that sort of thing. So we have that database, we have that information, and so what I would suggest is, after you've absorbed some of this information and heard from Leo especially, take this back to your jurisdictions and just know that we have resources available to you. We're going to be working on building a toolkit on this to try to encourage the development of and participation in these new programs. Okay.
Thanks, Paul. Okay. Thank you for that. Appreciate it. Wow, that was loud. So there's nothing like being the last presenter of the last segment of the last program of the last day before you get to go home. Now, the good news is I'm from Denver, so I just get to drive down the road. But it's great of you to have you here and to visit my city. I hope this has been a good conference. As Baldwin teed up well, there's a lot that the law does, and there's even more that the law doesn't do. It touches health insurance and health delivery in a lot of different ways. The purpose of this is more to talk about some of the things that it doesn't do directly, but still kind of pushes in new directions, how it affects markets. So this is a chance for you to think about your services and your business model in a different way. It's not about so much giving you the specific playbook of here's what you should do, but it's meant to give you a lot of different considerations and approaches that will allow you to go back and say, now we have a choice to go in a few different directions. How you choose to take that opportunity and how you choose to view the challenges ultimately will be up to you and what's going on in your community. But the foundation is what was described as the underlying problem by Baldwin, is we have this bolus of new people that are coming into the market. Prior to this time, insurance was a shrinking industry. Every year, the number of people that we had in the markets got a little bit less. That put a lot more pressure on providers, on the healthcare system, because that was unreimbursed care that they had to take care of. Now, all of a sudden, you have something government has done that usually doesn't happen in markets. You've turned a declining market into a growth market by putting millions and millions of people back in. And with those people are attached different revenue streams. It could be Medicaid, could be Medicare, and it could be the commercial markets, but getting something for those services is a lot better than getting nothing. And so the problem, as Baldwin explained, though, is the delivery system isn't really set up to deal with it. What it's set up to do is deal with all the people that were in the market getting the care that they were getting. And a lot of those people were getting care in less than the best ways. They were going through the ED or maybe not getting care at all, but even if they were going through the ED, they could have been using it as their primary care site. So there were a lot of people that were getting less than efficient care. And more broadly, the system is constructed, as you all know, as a scattered quilt of individual circles. Each one is unconnected to the next. Everyone focuses on making their own buck based on the services that are compensated for whatever it is that they're doing. And they're being paid by volume. And so they're focused on their own piece. Not that they don't care what happens outside their circle, but they don't have a financial incentive and arguably have financial disincentive to look beyond their circle. And so there's been a lot of effort all of a sudden where everyone says, we have 30 million new people coming onto the market. That's a big deal. They represent also a lot of money. And they create a lot of entrepreneurism. And that's wonderful, but a lot of those efforts are still done in silos. Not that they're necessarily bad. Employers may look at things like on-site clinics or their own wellness programs, but they're largely targeted to their own population. You have others that are like walk-in clinics. Again, not a bad thing, but they attack a little piece of the overall system. Some are doing okay, some aren't. Then there's other things. Telemedicine is growing. There's different tech companies, web-based companies that are creating solutions. And so you have now a bigger hodgepodge of things going up. And for the time being, everyone's still focused on making their buck in their little silo. You have, if you drive down the freeway over here in Denver, and probably like most cities, you have billboards popping up that say, hey, pop into the ED because we only have a 3-minute wait time and you get a free cup of coffee, right? Well, probably not the reason why you should be going to the ED if you happen to be passing by the billboard at that time. So not always the right focus when it comes to care. But one thing, while reform doesn't do a lot to address costs, it does set certain things in motion that have the potential to address costs. And one of those things is this whole concept of accountable care organizations, ACOs. This is not a new term. There have been integrated delivery systems around for some time, and there's been different types of providers trying to coordinate care in different ways. But what the government can do like no one else is, it's the 800-pound gorilla, and can give any initiative a kick in the pants. Make it much more legitimate, have much more momentum behind it than you had before. And so it put into the law these entities, specifically under the Medicare program, but legitimized them much more broadly in the commercial space as well. And so it said there's an opportunity for providers, usually physicians and hospitals, to collaborate clinically and financially to improve the outcomes for the patient and also manage the cost of care better. Now, usually big provider groups or hospitals are in the middle of this because they're the ones with the money. But as you well know, they don't represent the full continuum of care. There's a whole continuum around them that is arguably just as important and is responsible for just as much utilization that may be driven by some of those other entities. And so the law tries to address that by encouraging development of these organizations and in the process encourage different methods of reimbursement. The primary way for reimbursing ACOs is through some form of bundling of payments. Rather than saying, we're going to pay you for the number of things that you do to a person, we're going to pay you X amount for a whole continuum of care. It could be a global capitation where we're just saying, take care of the patient soup to nuts. Here's the money you get, period, over a larger population. It could be for ortho and cardiac services and other bundles. There's a lot of ways that you can approach this, but it's moving away from the volume-based. On top of that, what ACA does spur is also different payments based on how well you do with patients. So it actually will reimburse a hospital less for readmissions within 30 days of a hospitalization. Good incentive. Normally, you just get paid that much more if you're that hospital, right? Now all of a sudden, you have to think twice and you have to say, if I've taken care of a patient, I have some responsibility to keep that patient out of my facility. There's also star ratings, which consider the satisfaction of a patient with the care she or he received. And so now you have this direction where healthcare providers have to think differently about the services that they provide and how they're also choosing to organize their services and the outcomes that they create. It's not just about making money, but it's a path that they go to make that money. So when you get specifically to EMS, the law actually says very little. You have to consider ambulance as an essential health benefit, but aside from that, it doesn't really get into care delivery in any meaningful way. But if you think about it as a pebble in the pond, ACA is the pebble, and then you have ripples. But really, ACA isn't a pebble. It's more like throwing a moose in a pond. And you have all kinds of different waves and ripples going in all different ways. They're not these nice concentric circles. It's a lot of disruption. And all of that represents changes in the market that are going to be happening because of the moose. And some of it is going to be smells that come out and all kinds of weirdness that you can't necessarily predict because it's not coded into the law. We have different things that are just being set in motion by ACA. So you can make a choice. You can do absolutely nothing because you don't have a requirement to. There's nothing that compels you to do it. But the flip side is you have to know that the markets are going to be changing and trying to organize themselves differently because of all this push that's been created by these incentives, by these different types of organizations, just by the cost pressures that are out there in the market. And so within that, EMS has the opportunity to step back and you can rethink the services that you provide and the business model that you have to play in a much bigger sandbox. Both because you want to, but I would also argue because your services and your ability to expand that scope are that much more needed now because now managing care across a continuum is going to be taken much more seriously than it has under a traditional fee-for-service system. So the opportunity, first and foremost, starts with the emergency department. It's the greatest line of sight. You have 136 million visits across the country to the ED, and 16% or so arrive by way of ambulance. And like we all know, that's not necessarily the place that they should be. Really, the worst place that you should be, unless you really need to be there, is the hospital, because there's lots of sick people there. So the question is, how do you address the opportunity, or what is even the opportunity? There isn't a lot of study around it in the non-Medicare space, and those top numbers are all or are numbers across the country, so soup to nuts. When you specifically look at Medicare, the studies have been done, say about 15% of those that show up in an ED through ambulance really shouldn't be there. That's for a Medicare population. But we know Medicare is a more morbid population, so probably there's a bigger opportunity percentage-wise in the non-Medicare population. There's a draft white paper that I think all of you got copies of that was put out by Department of Health and Human Services. And this quote was taken from there. And just reading to you an excerpt, the EMS system is uniquely positioned to reduce the total cost of care, enhancing the quality of care received by all patients. And so there is this emerging view that you have a much greater role to play in addressing not just this 15%, but actually a much greater swath of the costs. And so if you think about the opportunity, not just within the ED, but beyond it, you also have a lot that you can do to affect care in ambulatory settings. There's this movement that is often labeled patient-centered medical home, PCMH. But there's lots of other names. There are references to medical neighborhoods and other different forms of care coordination that all weave one form or another to the ACO-like concept that I talked about. But the whole point is, if you can get different people engaged, different providers engaged in coordinating the care, and some providers to act more like quarterbacks of that care, you could affect care in all kinds of settings to both the benefit of the patient and the overall costs in the system. And so some of those pilots are okay, or really a lot worse than okay, don't show much. But the ones that are well coordinated actually show a lot of efficacy. There's a lot of good stuff. So this one in the second bullet had a 29% reduction in ED use and 11% reduction in care in ambulatory settings. So there's opportunity beyond the ED to crack the nut. A lot of PCMH is focused on the primary care physician. But when you take 32 million people and you throw them into the market, if you were to assign them, if every one of them chose a primary care doc, you would probably need about 20,000 new primary care physicians to care for that. If you think about the capacity of med schools in the country, and last I checked, it takes 4 years plus a few years of residency to get your MD, unless you do the mail-away thing, then you're not going to be able to pump out enough docs to care for these people through just primary care. So the role of mid-levels, through the role of a lot of other providers in the community, they're all going to have to step up to fill the shoes of what a lot of these programs are trying to accomplish, which is having a coordinated system that somehow manages costs better than what we have today. So if you take that as a goal, how do we reduce total cost of care and improve quality? You have different pathways that you can go down to help the system accomplish that. And in the process, again, play in a bigger sandbox. It could start with simply triaging patients without dispatch. Or if you do have dispatch, do you treat without transport? If you do transport, can you transport to alternate care settings? And then if you are transporting to ED, there's admissions, can you help with post-discharge monitoring? But then you could set that aside, that are all hospital-centric related services, and then shift to, can you provide scheduled treatments? Can you provide other monitoring, provide in-home services, walk-in services? Things of that nature become an education portal, become a referral portal that can help people guide around a pretty complicated healthcare system. And it's all of these things that efforts like PCMH are trying to accomplish, but that don't need to revolve around the primary care physician. So if you think about it as a new service model, and there's more than one way to approach it, this is one of them. The traditional path is just the vertical one. You get the 911 call, you get dispatch, and then there's really transport to the hospital, and it tends to be the emergent, whether it truly is or not, secondary. And then if you start broadening it around that vertical, then you have other opportunities where can you become the source for referrals, whether it's patient self-directed or directed from physicians, from hospitals, from other centers. And dispatch takes a much greater role to be also a source of triage and a direction to the appropriate treatment, sometimes often provided by community paramedicine, sometimes could be somewhere else, could be transport to an ambulatory setting, non-emergent. And so that you have this, to organize it, this division of services, where if it does come through 911, the traditional is that fourth box at the top where you transport to the emergency department. But if you take just the Medicare numbers, that would mean that that's 85%, and that 15% could be directed towards those first three areas, where you actually treat on location, you transport to outpatient center, non-urgent, non-emergent, or the third, you transport to urgent care facility. And so the estimates for the opportunity to divvy up that 15% of services are what you see in the parentheses. Got 25% on the first, 50 in the second, and 25% for urgent care, again, at least using Medicare estimates. So that's how you could affect that 15%. But I would argue there's also opportunity for you to touch the 85% to some extent that's going to the emergency department by going a little bit upstream. So if they're showing up in the ED, there may be an upstream reason, a root cause that led to that event. And so is there the potential for all of those services that I described before, where you do remote monitoring, especially if it's post-discharge. You're doing triage of the event, you're doing follow-up assessments, make sure there's compliance with the treatment protocol, support for home health services, or even scheduled services that all help avoid some of the events that would lead to an ED visit. And so this type of model is what's giving much more of a push to the term, to the concept of community paramedicine. It's how do we expand the scope, touch the unmet needs, and in the process expand the services that are provided by paramedics, to some extent through training, through resources you already have, or those that can be pretty easily augmented. So part of it, of course, starts with scope, with making sure that that after you identify the areas that you're going to go after, that you're able to get the trainings, the certifications to deal with particular disease states. Can you support management of CHF patients, for example, without them necessarily having to visit their cardiologist? Can you help them be a referral source or care manager as they try to interact with a pretty complicated care system, which is what PCMH is trying to do? What does your population look like in the community? Is it skewed towards a particular need? So do you have elderly, do you have special needs individuals? Or perhaps it's certain disease states. We have in certain communities very high prevalence of MS here. Every community has something that's going on that may be a bigger need than others, or that the delivery system isn't that well positioned to provide. And based on that, you decide which stream, which sets of healthcare services you could provide, from basic assessment to also education to some of the more sophisticated disease managements, but anywhere in between. And so as you go through this process, there's going to be a long list of considerations, and a lot of them are going to be based on both how your services are currently set up as well as what's going on in your community from a competitive standpoint, as well as what kind of services are already being provided, and throwing it all in the mix together. Beyond that, you're going to have to make your own list, but this is a starting point. So operationally, what are the things that you would need to address? What's the impact that you think that you would be able to create by doing things different? And the term different is a little bit of a vague word. That's for you to decide. How different is different? How deep in the set of services do you want to play? What is your scope of practice? See, how far does it even allow you to go? But there's going to be even reimbursement issues. So if you're transporting to an ambulatory care setting, does that provider have any kind of incentive to accept non-scheduled visits? Can't take them somewhere where no one's going to be meeting them on the other end. And how are you going to deal with physician oversight for this expanded scope of services? Do you have the data, the systems to monitor quality and report back on the things that you're doing? As you go through this, you're going to have a longer list of questions. And so what I'd like to give you is how do you start organizing things in a few buckets so that you could go down this path in a more methodical way, so that you could have a process. Probably the first two steps, and the more I talk about this, the more I'd probably flip these two, is you do a market needs assessment. Based on where your locations are, what's going on? Both what are the community, how has the community delivery system already been set up to provide services? And what are the needs out there that are not being met, or at least not being met well? And then who's going to be your competition based on the different tiers of services that you try to expand into? So basically, what's out there? A market scan. Along the same lines, then you have to be honest with yourself and say, where are you currently at? What are you positioned to provide? What do you have capacity to provide for? You have an obligation to provide core services right now. So before you expand, you have to think about where you're starting from. And then what's the training that currently exists, and what are the processes that exist for you to expand? And based on that, you may say, I can only take one step. It may be some basic services, some basic monitoring, maybe some scheduled assessments. That's as far as I can go. You may have the capacity, the wherewithal, to go to provide a full spectrum of services and act to some extent as a medical home, but only you're going to be able to assess that. Going through the process of operational readiness and just simply knowing your starting point across all these different services is pretty important. And then I'd flip the first two here as well. Who would you work with? So you've done the market assessment of who's out there, but if you're talking about expanding care, you're not going to do it by being a silo. You're going to have to work with either large physician groups, hospital systems, someone that is controlling to some extent or can control the flow of patient volume, because you're ultimately talking about increasing the volume that's going to be coming to you. And so how is that going to happen? To some extent, insurers have the ability to pay you for services, and you're certainly at some point likely going to have to talk to them, make sure you're a contracted provider for whatever extra stuff you're going to be doing. But they're not usually people that direct care. Sometimes, but not often. And so who are those partnerships? And in some cases, it can be government agencies because, as we know, Medicaid controls a lot of the contracting process with providers. And then you have to go through a modeling process. When I was talking about evaluation of the impact that you should have, you have to have a value proposition. What kind of outcome are you trying to affect? How much is it going to cost you to affect that outcome? What's the reimbursement that you could reasonably expect or maybe demand, depending on the position you have in your market, to get compensated for those services? And can you make the numbers work out? You're going to have to make some investment usually when you expand your scope. And so doing pro formas to figure some of this out, even if it's back of the envelope to say, do you have the basis to go forward? Do you know what kind of reimbursement do you need? Do you know, at least at a high level, what kind of discussions you would need to have with some of these potential partnerships? And then the last piece, which actually may be one of the first along with the market assessment, is what Baldwin described, looking at the legal and political climate. In some cases, you may have laws or regs that prevent expansion of scope of services. In some cases, you just may have politicians that have some objections to publicly funded organizations competing against private organizations. Happens a lot in a number of different markets, but it's better to know what you're going to be up against before you get too far down the path. And so sometimes it may be a change to regulation that you're lobbying for, maybe a change in law, a little bit tougher, and it may be a little bit of just simply greasing the skids and making sure that you have the political support that when you start going down this path, you don't get you'll be supported with any kind of backlash that may happen as a result of it. So as you go down that path, one of the key areas is where do you have common ground? Who do you have common ground with? Who's going to be a fit going down this road? And every community is going to have organizations at different stages. They may, just as one example, view your services as the same thing as just simply ambulance transport, and educating about the role of community paramedicine versus simply ambulance may be a necessary starting point for them. Maybe they haven't even thought about this broader view of healthcare, about managing across the continuum. They definitely know about it. They may have just chosen not to take any steps to go down that path. And so starting to go along with them, maybe nudging, maybe waiting till they're ready, would be important. As you go along the process, I would say, unless you have a lot of resources, it's always good to get some help before you get too far. Make sure that someone could at least point you to where some of the landmines are, what's been tried, what hasn't been tried. Get some guidance, at least on the financial side of things, to make sure that you're conducting conversations in the right ways. There's no particular playbook on who has to be your partner. It's going to be community specific. And sometimes it could be the dominant system, sometimes it could be an underdog, sometimes it could be a physician group that happens to control a lot of volume, yet maybe doesn't have a lot of size compared to the hospital systems, but has a lot of influence. And so making your intentions known, becoming aware about how you want to play in this, is one of those basic building blocks. Because every organization, every hospital group, to some extent every large physician group, is having these types of conversations. And most of them may not be thinking about you in that plan that they're creating. And so you may not come to an outcome through some of this, but how do you at least make sure that you start to introduce yourselves in a different way of thinking into their thinking? So as you go down that path then, if you find that common ground, you have to figure out what's the potential. And that's going to be based on what their view is, their intent is in managing cost and managing quality. They could be at the point where they say, you know what, not too worried, there's 30 million new people coming into the market, I'm in a good position, I'm going to be worried about a land grab initially. I'm going to just attract as much patient volume, fee for service, I'm not worried about care coordination. Even if I'm participating in a Medicare ACO, as long as I can crank up my volume enough, I feel like I'm in a good spot. But that's not going to be the game that they're going to have to play a few years down the road. That's okay initially. And so they may be acting one way now, but I can tell you for sure they are thinking about how their business model is going to change in the next few years. And so if you can get that interest, then you could start to actually explore what are the outcomes that they feel they're best positioned to create. How can you help them either accelerate their outcomes or expand the range of outcomes that they're looking at by introducing some of these services? Part of it will depend on how well aligned they are with physician groups if you're talking to a hospital, or if you're talking to a physician group, how well they're aligned with the hospital on the other side. But you have the ability to affect both sides of things. And so along with that, you need to get at least a feel for what could reimbursement actually start to look like. Initially, it just may be expanded services under a fee-for-service model, or it could be some portion of a piece of that bundling for the episode of care, could be a piece of the global capitation, it could be a whole range of stuff. But we had some questions in the last session about what it could look like. Everyone is trying to figure it out. Systems in place right now to actually make it happen aren't too great. So the direction everyone's going down is trying to make it more simple than getting overly fancy, not trying to boil the ocean. So I don't think you'll be hit with anything that's too out there. But you want to know what you're up against, at least through these initial conversations. And then making sure that you include in that conversation, the starting point is going to be ED hospitalizations, because that's how the current system is structured and how you're viewed as playing in the system. But to make sure that you expand their view, say there is this ED opportunity, hospitalization opportunity, but there's also this opportunity to affect care in ambulatory settings. And so as you do those explorations, the side note is don't sign anything. Don't do letters of intent. Make sure that you get counsel before you do this, because I've worked with a number of fire departments that get into everything from different forms of bargaining arrangements to collaborative arrangements where they're trying to expand scope, and they lock themselves in a box, too small of a box, too early, and then their hands get tied. The whole point of this is to make your intentions known, to identify opportunities for collaboration and for yourself to get educated on where your market is so that you can take the right next steps that make sense as a business. And as Baldwin mentioned, every state is at a different place. A lot of states don't have limits on scope of practice. Some do, whether it's legislative or regulatory. But even those states are looking at different ways to expand scope. And so some are tougher than others. California's tougher, Florida's tougher. Some are much more receptive to these different models because they get the primary care shortage, they get the whole cost problem and the need to approach the cost problem in different ways. And so whether it's you take advantage of new expansions in scope, pilot programs, or you're trying to influence them, the whole political portion of your strategy has to go alongside everything that I've talked about from a business standpoint. The thing to recognize, though, is I get that I've been high level. And I've been high level for a reason. Every market's healthcare situation is different. How the delivery system is structured, what the patient needs are, competitive environment, everything. And so there isn't really a playbook. There is an approach that you can take. And then based on where you find receptivity, where you find opportunities, unmet needs, will guide how you take that next step. But the most important part is take a step in the right direction and recognize that you're going to encounter obstacles. Because a traditional approach of a hospital, for example, is to control. Usually hospitals are the 800-pound gorillas in their market, particularly if they become integrated systems. And so they may own a lot of the systems around. They may view that they don't need anyone else. But even through the ED opportunity, there's enough data to show that there is a chance to do something different and for them to have better outcomes at lower costs, and especially if they're getting capitation for some of their services, to make more money in the process. But you may be initially up against, I want to control and I'm going to dictate to you what to do. And so this will be probably longer than a shorter process. You'll get pushback in other ways. You'll be seen as a competitive threat by anyone from, we were talking in the last session, if there's a nurses union, California Nurses Association, CNA, has a huge lobby, right? And you would be, as mid-level, stepping on their toes. It could be other ambulance providers, could be a hospital that owns a transport company. And so you may bring a lot of value to the table by becoming a neutral third party that can get rid of some of that competitive tension, or you could be seen as someone that's taking away differentiation from a hospital because they may own a set of services that they think makes them more valuable in the marketplace. And so being able to prove that value proposition of what exactly you think you could affect that makes their financial position better is going to be important. And then obviously, because you are publicly funded and competing against private companies, you'll get pushback both from those private companies and potentially political officials as well. And so the earlier you can start the conversations to explain, I think if anyone is well positioned to say they are truly focused on the greater good, it would be you guys. And so the earlier you could start to approach it before the pushback starts, the better you're positioning yourself. So the next steps that I would tell you to take are the ones that I've described and just packaged here a little bit. Is first, just start going down the path and make a decision. Are you going to start exploring or are you not going to start exploring? It's not a right or wrong, but at least know that all of these things are going to be happening around you regardless of the direction that you choose to go. And the longer that you wait to make your intentions known to start going down this path, the more you're going to be left behind, and there's going to be some plans that are put down going left when you really wanted to go right, or you're not included in that left-hand turn. And so starting those collaborative conversations, exploring some partnerships, doing that honest check about how you're positioned operationally, maybe dipping your toe in the water by expanding scope a little bit, figuring out what kind of reimbursement structures are in your markets or emerging that you could take advantage of, and how it is that you think that you could drive value, and communicating that well are all pieces that should be manageable to start off with. And then depending on what you find, then you can make the choice to take the full plunge or not. But hopefully this has given you at least a starting point to start thinking about what service expansion, what business model expansion means to you. And with that, we have a little bit of time for questions if you want to throw some things at us. Yeah, please. And I'll ask, since we have mics, thank you very much.
Hi, two great presentations that left me far from satisfied. And
That was my intent. Thank you.
I'm certain. And I'm Dave Prezan from New York City. Nice to meet both of you. Well,
Likewise.
you have already met. And I think, as you said, every group is going to be different. Every location is going to be different. So I can only speak from my perspective. You know, we do in New York City 1.3 million EMS calls per year. We're not sitting around doing nothing. And I don't mean to imply that other people are, all right, because I think you're not. I think you're more like us, just on a smaller scale, all right? We're not sitting around saying that our biggest mission right now is to look at new business opportunities. Mm-hmm. I understand we better, all right? But that's not what we're looking at. Right now, what I'm looking at when I think about the Affordable Care Act, which I don't think you addressed at all, is how can I deal with my main business issue, which is doing 911 EMS calls, all right? I'm not worried right this minute about whether I can bill somebody, some old lady in a house, to take her blood pressure, all right? And I actually think I can do that really well, but I think in the long run, I am never going to be able to compete with physician assistants and nurse practitioners who can prescribe medication, all right? So I think there's a real flaw in this plan, the plan you have for expanding care, when paramedics, no matter how good they are, and I think they're great, can't prescribe medications, all right? And I think that there's a real flaw in this when you're talking about fire departments that don't have a lot of medical directors, aren't thinking about the huge burdens that this is going to have in terms of quality assurance. But before I even get to all of this, and I don't want to sound like an old person. I mean, I'm challenged by all this. I'm interested in all of this. But my main concern right now is how do I reimburse my services under the Affordable Care Act for what I do every day, which is going to a 911 call. Right now, that is a fee-for-service concept, all right? I am desperate to separate out the patient care from the transport. But I'm billing CMS or insurance companies or whomever for that. It seems to me in affordable care that hospitals, large physicians groups, but mostly hospitals, are going to grab all these patients under a capitated fee. And I'm concerned that CMS will not have any ability to pay me, that insurance companies will not have any ability to pay me unless I form partnerships with the hospitals that have gotten the capitated fee. And you don't address that at all, but that's 100% of my business right now. All right? And I think that's 100% of your business. All right?
Yeah.
All right? So before I can figure out how to go compete with nurse practitioners about how to check a person's blood pressure and, you know, change their dressing, I got to know how I'm going to be able to keep billing for the services that drive all my ambulances constantly.
So you made a lot of comments, and the point's well taken, so I appreciate that, and I recognize that there are a lot of challenges under the reimbursement environment. A little bit about the presentation. We focused the presentation in this way specifically because that was the request. It was to identify what new opportunities are. I would challenge you that it's not 100% of the cases that everyone is in your boat, because you can actually find in the press, we've worked with departments, with EMS organizations, and there's others around the country that are very much looking at it in this way. With that said, they also have the foundational challenge of how do I manage what I have. And so what we touched on, but that you articulated, I think, much better, the overlap is you do need to expand how you function from just a fee-for-service organization to establishing linkages with other organizations. Now, everyone is making the march to capitation or bundled payments slowly. If you look at the number of programs out there, everyone is dabbling. You have one over here, you know, Geisinger messing around with ortho and someone with cardio, and really you can construct pretty easily about 52 bundles. So it's like, well, what are you doing with the rest of them? So, and how does transport come into it? And so there is a march in this direction, but it's a slow march because everyone is trying to understand and get their systems and processes in place. In your situation, I would say, yeah, you do have to, like you said, figure out how to partner, make sure you don't get cut out of the capitation. But what I would say that this proposes is also, is there an opportunity for you to look at your business model a little bit differently? Because the question that I got in the last session is, how do I protect what I have? And my contention is, understanding I don't do what you do every day, is you have very little opportunity to protect. You have to be proactive in creating a new business model, and whether it's getting a piece of that capitation, but I would say just as much changing your revenue stream to some extent by looking at these other services. And you may find that opportunity by starting off with, hey, you're going to be getting a capitation. What's my piece of the capitation? By the way, how are you handling all of this other stuff? And yes, you may not be able to prescribe, but you know what? If you are getting a cap and I can divert, you're not going to divert all 15%, but if I can divert some of that under your cap, you're making a hell of a lot of money. And so then you create a lot of openness to the conversation that's not just how do I get compensated for taking someone to the hospital, how do I decouple patient care in that? And I know I'm not doing a great job of answering the question, but the point of it is more, get in the conversation, elevate it to beyond fee-for-service, elevate it to beyond current services that you're providing, expand the scope of services that they're willing to discuss with these different organizations. Otherwise, I think you're stuck trying to protect turf that is going to continue to get chiseled. Yeah.
And also, let me just add real quick. You know, we don't actually. Part of the problem with the capitation and that those billing practices that we don't really have that much guidance on that. You know, Medicare hasn't issued a new sets of regulations on how they're going to do that, and they're not tipping their hand. Part of it is that the Affordable Care Act doesn't really say very much about that at all. In fact, it says zero about that. And that was one of the things Leo alluded to, that the statute is creating a whole new world of new customers and strains on the system without really addressing how a lot of these strains are going to be addressed. To some extent, CMS has been empowered to address a lot of these cost issues, but they're not telling us how they're going to do it. And I don't blame them right now, because they're worried about standing up exchanges and insuring 32 million new people. I can say, for what it's worth, that we're monitoring that and constantly trying to figure out what's next, what's coming down the road, and that's part of what we're supposed to do from the international perspective. Let me also say, just as an aside, you're the doctor. You know much more about this than me. But I do feel like there is definitely a role for non-prescribing healthcare providers, and I feel like there is an opportunity, whether it's health counseling for a type 2 diabetic, or simply helping someone understand their medication regime that's been already prescribed. It's things like that, wound dressing treatment, things like that.
You could always count on the New York guy to ask the tough questions. No, I thought it was a great question. Thank you. Can I, Mike, please?
I was going to offer to the doctor, and I appreciate your point, but anytime I come to an IFF or a state event, it has to be spread to so many people. I actually work for probably one of the larger departments in the country that doesn't provide EMS service, or we provide EMS, but we don't do transport. Good for us, which is great. However, this is actually, I appreciated this presentation as well as the one before in the next room, the community paramedicine, just because we're trying to find a way to remain relevant and we don't bill. So we don't have a way to bill because we don't transport. And we're a large metro department, but trying to remain relevant and politically sound. We're very politically active in what can we do to use this to our benefit. And as well, being an officer on an engine company, I'm able to, without prescribing medication and being a paramedic as well, I'm able to treat a number of, not really treat the patient, but treat the incident, manage the incident, and put it to rest by doing a refusal at scene or an AMA that works right under our medical director, another physician. But I appreciate the presentation, and I take the doctor's point, but that's just kind of the way I look at this.
Yeah, and I appreciate your comments. I don't want to make it this about us, but I think it's really cool. So I just so that I'm clear on the record, I'm not against any of the things that you guys are doing, and I think that one of the greatest things that paramedics and EMTs and fire people can do is to not transport someone who doesn't need to be transported. I think that's one of our key, most important things. And I think we can be trained, and with proper quality assurance, and I think we already are trained, that we can do that every day. And I think the current CMS system of not reimbursing you if you don't transport is ridiculous, and I think one of the best things that we can do, and I've talked to the IFFF, and Dr. Moore is very supportive of this, one of the best things that we can do to prepare for this, but also to deal with our current state, is to separate out and get CMS to bill for the patient needs. Treat and release. Yeah. We go, we respond, we treat, we release, or we bring to an alternative destination. We should still be able to bill for that, and then there should be a separate bill for transport. And that would take care of a lot of the things you're doing. But let me mention that there is a group that doesn't prescribe that has been doing very well, and I think we could compete against that group if we wanted to. And that's the visiting nurse services in everybody's community. So they do the things you've talked about. They go, they take care of your blood pressure, they make certain you understand how to take your medicine, they do dressing changes, and our guys and gals can do that as well, if not better. So sure, there's a business model for us to compete. All right, I just don't think we can compete with nurse practitioners and physician's assistants. So it's choosing your niche. That's all.
I think
that's all
right.
I was saying.
the one thing that is a theme that's coming, what you see coming out right now, which was also in the prior session, is you get some basic food for thought from these kinds of presentations, because you have two individuals that are right here in different positions, and then people start bringing up different approaches that they've already taken because of their community, the setup of their services. And so the more that you could create, I think, round tables amongst yourselves to share these experiences, I think the more you can build on just the things, the tidbits that you get in this type of presentation, and continue to expand on it by learning from one another.
Can we have that? There's one last question, I think. We'll be around afterwards to.
I guess I'm under the impression that Medicare and Medicaid are still going to stay. Is that correct?
Oh, yeah, yeah, there's,
Okay. And I'm also under the impression that in my ambulance, I can only transport to the hospital to get reimbursed by those two providers.
Currently,
Okay.
yeah.
With this new Obamacare, if I'm taking Jethro to the hospital that has a 1 centimeter laceration to his pointer finger, I might have the latitude of taking him to a company care
Well,
clinic.
That was his question and his point, and it's well taken. And in fact, we are trying, for what it's worth, to try to get Medicare to address this. But I just think that's task number 300, and they're at 74 right now. But I do believe, I think a lot of people believe that that kind of treat and release approach can, should, and will be billable, because at a lower rate, obviously, than perhaps transport.
And
but
I see
can I
that.
add, we're not just talking about, I get Medicare, Medicaid is a huge chunk of services. We're also talking about going beyond Medicare, Medicaid, and so what are the protocols for commercial reimbursement as well? Because a good chunk of these people on the market are going to be non-Medicare, non-Medicaid.
Well, I also see by working in the field, the reason they call for 911 is they have no family, they have no means of transportation. They actually, for the most part, understand they probably don't need an emergency room, but they do need to be seen by a physician or medically evaluated, and that's their only option.
Yeah.
You know, I think Obamacare, I don't know if I like it or not. There's so much to it, I'm totally confused, but I think it could be very simplified just by changing just a few things,
Yeah.
you know?
Well, I think one of the points of the brief overview I gave on the whole community paramedicine concept is, can you be that local resource for treatment? I mean, in my case, I have access to those kinds of services if I were to have a minor incident. 1 mile one way and 2 miles the other way, and the nearest ED for me is about 7-8 miles or so. And so if I did have the 1 centimeter laceration or didn't have family or whatever it is, that would be a great place for me to go. And so this comes back to, what are the community needs that you see? What kind of transports are you currently doing that you feel shouldn't end up in the ED? You do have restrictions when you're dealing with government programs right now, but you may not have those restrictions when you're dealing with commercial payers, or have the ability to affect them much easier. Because I could tell you, any commercial payer would love to have you take some alternate treatment or triage rather than having them show up in the emergency room. They would pay you to do that.
Okay, I think we've gone over.
And we have gone over. We'll stick around if people do want to talk, but if you're taking off, safe travels, everyone.